Hi, my name is Galvani. I'm a diagnostic radiologist. In a few moments, I'm going to share with you the screen of my workstation when we'll be able to see everything I see on about 10 or 12 CT scans from the emergency. We are going to go over the images, I'm going to comment on the findings, I'm going to show you everything I see as pathological or normal, and we are going to eventually reach a diagnosis. Then I'm going to report the exam and comment on terminology, what should be reported, what shouldn't, why I do this or that, and all that good stuff. So if you are interested in such content, please stick around and comment below if you have any questions. So let's get to the images. This is our first exam. This is a 79-year-old female patient. It's a chest CT scan, and she says she's a smoker. She is a smoker for 50 years, has hip pain on the right, difficult breathing, hypertension, diabetes, and cough, productive cough. So no fever. This is a mystery. Let me get my template for chest CT scans of the elderly. And also, the internet connection is quite fast today, so I guess we'll be able to work just fine, which is nice for a change. So, just some few more seconds, and I'll remember to anonymize the exam so you guys can't see, of course. Oh, it's already anonymized from our previous session. So this is a chest CT scan of a very old woman, and we're looking for a motive for productive cough in a case of a heavy smoker patient. So this isn't good. There are axillary adenopathies, large lymph nodes on the axillary regions. There are also adenopathies, lymph node enlargement all over the mediastinum and the ilum, the ila. So this isn't good. I can also right away see there is a solid pulmonary nodule right here on the upper right lobe. There are numerous micronodules all over the place. Let's scroll down. The heart is normal sized. There are some atherosclerotic changes on great vessels and coronary arteries, which is expected. She's almost 88 years old. Some bends. There are no consolidations, just this one irregular nodule, non-calcified, on the posterior segment of the upper right lobe. There are some bronchiectasis and paraseptal emphysema. Multiple. This is a calcification right here, a calcification. This is residual, just scar tissue calcified. The micronodules are predominantly centrilobular in localization and location. So also a few subpleural bullous or bubbles or blobs or blabs. You choose it. I don't know how you guys call this, which is just a bunch of air pockets just below the pleural, due to chronic pulmonary disease. It's quite common in patients with emphysema. Also, I can tell the airways are partially occupied by anomalous material, which in itself is a pretty acceptable reason for coughing. So this is it. This is a very peculiar case. The thyroid is also not normal. Yeah, normal. Did you guys hear that? Yeah, my voice is acting up. One. And the spine shows a lot of degenerative signs, degenerative disease signs. So let's report it. This is a very peculiar case. These micronodules and this nodule could be cancer related, but could be also infectious in nature. Not much this nodule right here, but the micronodules could be. There is surprisingly very little emphysema, considering this patient is a heavy smoker, and no consolidations whatsoever. The thing that concerns me the most are these enlarged lymph nodes all over the place, especially on the axillary region. This isn't common. This is quite uncommon and usually related to much severe, deadly disease, such as neoplastic syndromes related to the lymphatic system. The spleen is also enlarged, so it could be there are adenopathies, there are lymph node enlargements on the abdomen as well. So we could be seeing here a case of some kind of lymphoma or leukemia related to the elderly, showing itself by in a regular CT scan searching for pneumonia. So the major concern of this patient isn't really the pulmonary signs of acute disease, but the chronic signs of lymphatic disease that could be justified by some kind of cancer, blood or lymphatic related cancer. The spleen is really enlarged, at least moderate enlargement of the spleen, which is completely incompatible with a 80-year-old female patient, no matter the complaints. So be sure to report these findings as a footnote on the report, so you can alert the referring doctor about the possibility of something much more severe than just irregular pneumonia on a chronic pulmonary disease patient. So COPD isn't the motive for this diffuse lymphatic disease, lymph node and spleen disease. So there is no pleural effusion. I'm going to start to report this case now. Feel free to skip ahead. In the description below and in the progress bar of this video, you will find the chapters. I have marked the chapters so you can skip ahead to the next case. and if you want to stay, I'm going to report the case and mumble to myself a few words. You might actually learn a bit more about this case just by the description of the report itself, but some people find the typing and the mumbling annoying, so I leave below in the comments the timestamps for each case on this video. So this is a very little this is a video with very little to none editing, so I'm not going to edit and lose time. I'm just going to record it and publish it on YouTube. So feel free. I'll see you in the next case. So for those who have stayed, I'm going to speak of the thyroid now. It's enlarged and heterogeneous, so these are signs of chronic thyroid gland disease. There is no pleural effusion, but there is emphysema. And subpleural lobes of air. So, what else? Oh, the nodule. Let's measure that nodule once again. So, zoom in. Irregular shape and margins. 1 centimeter. This is the posterior segment of the superior right lobe. Posterior. Yep. Now the micronodules. So, a bunch of micronodules. Now the anomalous content on bronchi, on airways, especially on the lower lobes. So, yep. What else? Emphysema, micronodules. I'm going to report the axillary lymph node enlargement. Let me measure the short axis. It's 1.4, 14 millimeters, 1.4 centimeters. Now, heart is of normal shape and size. Now, lymph node enlargement on the mediastinum. Let's see how big the lymph nodes are. No, usually the subcarinal, infracarinal, subcarinal are the largest one, just below the carina, which is the splitting, the bifurcation of the trachea, bifurcation. The bifurcation is called carina, and the subcarinal lymph node is usually the largest lymph node related to the trachea. So it's easy to go there and just Measured is 1.4 centimeters. Easy peasy. What else? For the chest CT scan, that's it. So let's summarize the report so the referring doctor can read just a tiny bit of the report and be happy about it. Emphysema. Atherosclerosis. Now I'm going to make a footnote to signalize to point out to the doctor that there is probably something wrong with the lymphatic system of the patient, some kind of lymphoma or leukemia related disease because of the spleen and lymph node enlargement. So here we are done. Oh, it's me. I missed the bronchi disease, the bronchopathy. Yep, that's it. Let's clear the cache and grab another exam from the emergency. Let's go. A chest CT scan, quite the opposite because this is a 1.5-year-old female patient. We're coming from a very old patient to a extremely young patient, and this is a CT scan of the chest to look for a pleural effusion. So pleural effusion in a baby most probably is related to pneumonia. So pneumonia with pleural effusion is the most common cause of such complaints. In a few seconds, 10 seconds, we are going to finish the downloading of the exam. It has been downloaded. Let's see what we have here. We have a very poorly done CT scan. Oh, one of the worst. They did for some reason, they did a contrast enhanced phase of a chest CT scan of a 1-year-old, which of course is terrible. This is one of the worst exams I have ever seen in my entire life, and I have already reported over 100,000 exams. This is really awful. So this is really awful. I can barely tell what the heck this is. So this is what we have for today. We can't really complain much because, as you guys know, this terrible, awful exam won't report itself. So the patient was literally shaking and trying to get out of the bed as the scanner was running, of course. She was very badly positioned. Can't really say if this is intrapulmonary or pleural. This is just sad. Oh, there is a huge loculated, huge heterogeneous left-sided pleural effusion and almost complete collapse of the left lung with a bit of preservation of the upper lobe. And on the right side, all I can tell is there is no significant, no real measurable pleural effusion, and the lung appears normal. The heart is of the correct size. Contrast enhancement didn't help us in anything. It's more of a confusion factor than anything else. This is a very, very badly done CT scan. There is a central line, venous line on the left, well positioned, and airways seem to be patent, and I believe this might be pulmonary necrosis. I'm going to report this as pulmonary necrosis. So this is it. Large pleural effusion, almost complete collapse of the left lung, and a very, very poorly done CT scan of a child. So feel free to skip ahead if you want, or just stay with me as I report this case so you might actually learn a bit more about it. So huge pleural effusion on the left, left pulmonary collapse, So this is it, this is finished. Let's go to the next exam. Let's see if we are lucky enough to actually get some exam that there is. We have now a abdominal CT scan. This is also a child. This is a 5-year-old male, and it's a appendix. It's a exam for appendicitis. So is this child Does this child have an acute appendicitis? Let's see. Just grabbing my template. I have already hit the download button to get the images. The images are about to get to us. So the download has ended. Let's load the exam, and of course this is also a terribly dumb, malpositioned and all shaky CT scan, because it is a child and people can't really do child CT scans, which is terrible by itself. So So let's see if we can actually see the appendix. I'm quite sure the appendix is this very peculiar shaped structure right here, but I can't really tell because this is really shaky, and they should have used rectal, endorectal, retrograde contrast enhancement for this case, because it makes it really easy to see the appendix in such cases, because small childs have very little abdominal fat, intercavitary abdominal fat, so it's hard to tell the bowel, the appendix, and the colon from itself from one another. So let's just measure this spleen. Yeah. This is most probably the appendix. I'm just going to measure from here to here. It's 5 millimeters. Also, there is no sign of an inflammatory disease on the right inferior quadrant of the abdomen. There isn't intraperitoneal fluid. So this really doesn't look like a acute abdomen. So I'm pretty sure there is no appendicitis here, so I can't really tell it for sure unless I can see the appendix from end to end, which is not the case in this exam. So I'll be sure to report it as it is and hope for a better acquisition, a new exam of this patient, so we can be sure, or if the referring physician thinks this is enough, he can just go with it. So that's reported. Feel free to move ahead. Excuse me. So just leave a footnote. And we are done. Let's move to the next case. The cache is cleared, and now we're going to go to I guess this is a trauma patient because she has gone through 1, 2, 3, 4, 5 exams: superior abdomen, head, pelvis, cervical spine, and chest CT scan. She is a female patient, 56-year-old. I'm just hit download, and let me see here the history, the clinical history. It says nothing. It says anemia. Patient is anemic or anemic. Makes no sense whatsoever to do spine CT scans of an anemic patient. What do I know? Yeah. This is some kind of oncologic patient that has been put through a emergency setting just to get quicker CT scan results, and this is what it is. So the download has ended. We have here chest, head, cervical spine. Might be there is no abdominal CT. Oh, there is. I should have downloaded it. Yeah, chest and abdomen are all together on a single exam. This is a very, very poorly done CT scan. This is one of those. This is one of those terrible CT scans. So let's start with the easy one. The easy one is always the brain CT scan. I'm sorry if the neuroradiologist guys are watching, but we all know CT scans of the head are the easy peasy ones. So there are slight, tiny, little degenerative disease signs, some atherosclerosis of the internal carotid arteries. Also, the brain is reduced in size, and there is a little enlargement, compensatory enlargement of the ventricular system. No signs of neoplasm, infection, or hemorrhage, no bleeding, no infarction, no nothing, just a regular old age CT scan of the brain. Let's go. Just open this up as much as I can. So, brain CT scan, first of all. just a quick one, and then we're gonna go to the chest CT scan. We're gonna go to the cervical spine. We're going from the top of the head to the pelvis. That's easier like that. And it's only going to get worse in exam quality. Exam quality wise, it's going to be worse and worse. So there is no contrast enhancement, and we have finished. Let's go now for the cervical spine. I'm pretty sure the cervical spine is all shaky, almost impossible to report, and is completely destroyed with degenerative disease signs. Yep, shaky as always, very badly done, and all shaky, all blurred. But it is what it is. What can you do? I can't really do much except report this terrible exam, because as you guys know already, exams just don't report themselves. Unfortunately, they say ChatGPT eventually will report exams. I'm eagerly awaiting for that time to come, so I can hire a bunch of ChatGPTs to do my work for me and just earn the money. That would be nice for a change. So the discs are quite normal. There are some osteophytes on the anterior and lateral margins of the cervical bodies, vertebral bodies. There is some arthrosis of the facet joints and the oncovertebral joints, and no stenosis, no fracture as far as we can tell, because this is a all shaky and blurred, very badly done, poor quality exam. But it is what it is. Let's just report it and get on with our lives. There are a bunch of other exams to report right next to this one. So there is hypertrophy, diffuse hypertrophy of the perivertebral muscles, and the patient is extremely obese. This is a really large patient, extremely obese patient, so it really doesn't help much either way. Still I can't tell the reason for these exams. I thought this was a trauma case, but it seems it isn't. And I still can't tell why this is what it is. But let's go to the next one. The next one is the chest CT scan. So this is the mediastinal window and the lung window. Let's see, the chest entry here. This is an enhanced CT scan, all shaky and blurred, just like the rest of it. I have a template here for all people CT scans of the chest. Of course, I'm not going to type every single time the entire report. I'm just going to change what matters. So now this is really abnormal. There is a moderate pleural effusion on the right and a small pleural effusion on the left, and there is diffuse consolidation of the lung parenchyma and also ground glass opacities all over the place. Also, the right pulmonary lobe, lower lobe, is partially collapsed. So I have a partial collapse of the almost the entire right lower lobe, and a partial collapse of the basal segments of the left lower lobe, and almost entirely the rest of the pulmonary parenchyma is abnormal. It is septal thickening, smooth septal thickening, confluent consolidations, and diffuse ground glass opacity. So this is a extremely sick patient right here. So I have some atherosclerotic changes, really mild atherosclerotic changes. Most probably I also can tell there is some kind of coronary atherosclerotic disease right here. The heart seems enlarged. It might not be, but I'm going to report as if it was. I'm just going to measure the ascending aorta to see if it's big. It is right there, not big, not small, so I'm going to pass just to look for mediastinal adenopathies, enlarged lymph nodes, lymphadenopathies. I can't really pronounce that. I've got to work on my pronunciation of those PH phonetics. I can't really tell if there are. This is so shaky and badly done that I can't really tell if there are enlarged lymph nodes or not, and so there should be very important enlarged lymph nodes. So let's report this chest CT scan and get on to the abdominal CT scan, which is the last one, because this patient has split superior abdomen and pelvic exam. So there are another 2 exams of this patient right next to this one. So there's a moderate right-sided pleural effusion. And subtotal, almost complete collapse of the right inferior pulmonary lobe and a partial collapse of the left one. Consolidation. So we don't really have any useful clinical history of this patient, but we can we could tell if we had any clinical history that this patient could have some kind of heart failure disease, because we have pulmonary septa thickening, smooth. We have consolidations and ground glass opacities and bilateral pleural effusion, which is larger on the right, and an enlarged, diffusely enlarged heart. So this could be a end-stage case, a acute case of congestive heart failure. But in order to report it like that, we should have some kind of prior clinical history that would point towards that direction. So if I report it as congestive heart failure and the patient is known to have a good working heart, I could be directing the entire clinical investigation to a completely wrong way. So it's not safe to act like that. It's really easy to be wrong. So when it's really easy to be wrong, you shouldn't push it. You shouldn't be wrong most of the time. So I'm going to describe it as I can tell, and I'll leave to the referring doctor to put the puzzle together and reach a proper clinical diagnosis. After all, I'm a radiologist, I'm not a referring clinician. So, see, the heart is enlarged. Can't really tell if there are adenopachias, lymph node enlargements. I'll just summarize the report to make it easier for reading. Yep. And we are done with the chest CT scan of this patient. Just read once again to be sure I didn't miss anything. I know I didn't. So next up is the superior abdomen, also an unenhanced, all shaky and blurry CT scan of the abdomen. So let's go. I have a template for such cases. Of course, I've been doing this for 16 years. So let's see what we can tell about the superior abdomen of this patient. I'm just going to make it bigger for you guys and for me. And let's go. There is some abdominal peritoneal effusion, some ascites or ascites. It's large because I can see it all over the abdomen from the upper quadrants to the lower quadrant. So it's a large ascites or ascites, a large peritoneal effusion. There is some calcifications. This exam is mostly artifacts of all kinds and sorts, so it's quite difficult to tell. any disease from it, so we're going to do our best, because this exam must be reported no matter what, because exams to this day don't report themselves. I don't know if you guys have noticed it. This patient is a bariatric surgery patient. There is clearly a gastric surgery here, which is a very common gastric bypass morphology. So this is the left out, this is the gastric pouch, the feeding limb, and this is the left out gastric remnant. So this is the biliary limb. So feeding and biliary limb. I can also tell that this patient has done this surgery for quite a long time, because the gastric pouch is already quite distended and she is still heavily obese. So this is probably another case of gastric surgery failure on the second, third, or fourth year. We know after the first couple of years of gastric surgery, most patients gain back the weight. So it's usually a failure. But we can also tell that there is a lot of calcified stones inside the gallbladder, and if we measure as much as we can also tell there is mild to moderate, this is so bad, mild to moderate liver fat deposition, liver steatosis of the liver, hepatic steatosis. So the spleen is of the right size, the pancreas is looking as normal as we can tell, the adrenal glands are okay, the kidneys seem fine, and there is ascites, free fluid inside the abdominal cavity, colon and bowel are fine. This patient has gone through surgery. There is a scar of a longitudinal median incision. Can't really tell much more than that. There is an atrophic uterus. Rectum is a rectum, not much. It's diffuse degenerative disease of the lumbar spine. I'm just going to do an NPR real quick, just to see if I'm not missing any major disease of the bones, just plain old severe degenerative disease of the spine. Also, if you guys have noticed, which is quite common on severely ill patients, there is diffuse edema of the superficial soft tissue, just like that. If it's asymmetric, which we can really tell here because the exam is very poorly done. But if we have a severe asymmetry of soft tissue parts edema, we should consider the possibility of a venous thrombosis, usually of the left side of the left lower limb. this isn't the case. I'm just remembering other cases I have seen, because severely ill patients tend to have lower lobe thrombosis. So that's reported. Feel free to skip ahead to the next case. I'm going to report the superior abdomen and take a section of the report, copy and paste to the pelvic exam, which makes my work much easier. There is steatosis, gallbladder stones, spleen, adrenal glands and pancreas are normal, kidneys are normal, atherosclerosis of the aorta. Let me just check. Yep, a little bit of atherosclerosis, nothing major. No kidney stones. Large intraperitoneal free fluid. There is a urinary bladder catheter here. This is the thingy that we inflate to make it stay there inside the bladder. This isn't the bladder, this is free fluid. So I have to say it in the report. And that's it. Let's just summarize it to make it easier for reading and quicker. So we have finished the superior abdomen. Now we're going to do the pelvis. Same old, same old. Just copy and paste it just too much. Just a small typing error. I'm going to take out the phrases that refer to the superior abdomen and leave it as a lower abdomen scan. And this is it. Thank God we got through this terrible, horrible, horrid, boring scan, but it is finally reported. So let's go for a face CT scan. Face CT scan of a 67-year-old patient from the emergency department. It says she has a nasal, which means nose, nodule on the right, and she also has gone through a brain surgery 20 years ago. There is no trauma, no nothing. So I'll just get a template. So the template is here. Oh, my back hurts. I'm out of coffee. And I'm going to hit download. Let's see, there is no previous exam for comparison. And we gotta go through this other exam. This exam is downloading. We are already 1 hour in, so this just might be our last exam for today. If you haven't already, it's time to hit the like button, subscribe to the channel, and share this content with people you know enjoy radiology, diagnostic radiology. I thank you so much for your audience, for watching, and we have here our last exam for today. So oh yes, this isn't good. Did you guys see it? This really can't be good. There is a monster on the right nasal cavity, just a huge monster right here. Oh crap. Yeah, this can't be good. Let's see the NPR button. Let's grab a coronal view, because the coronal projection is always the best projection for sinus cavities, for the nose, the face, and whatever. There is a mass, a soft tissue attenuating mass that occupies the choana, the posterior nasal outlet. It's very aggressive. There is bone erosion all over the place. Bone erosion on the floor of the sphenoid sinus, also of the ethmoid bone, and also erosion of the osseous nasal septum. So also the middle meatus and the medial wall of the right maxillary sinus is eroded. So this is a aggressive infiltrative mass on the right nasal cavity, and the most common diagnosis in such patients, such an elderly patient, is spinal cellular carcinoma. So this is probably a major case of cancer, and the rest of the right-sided sinus cavities are also diseased, are also sick, filled of heterogeneous content, and with diffuse thickening of the mucosa, because the outlets of those sinus are obstructed by chronic inflammation, and also this expansive and infiltrative behavior of the tumor. So the sinus cavities and the nasal cavity on the left are much better, but they still have signs of acute disease, not chronic but acute disease. And the orbits are fine. Let's see the masticatory spaces. Masticator chewing spaces, the buccal oral spaces, and the base of the neck. Also the temporal bones, petrous pyramids are fine. The base of the skull is fine except for the eroded walls of the left sphenoidal sinus cavity. No, this is a major tumor. Let's measure it on 2 axes at least. So for the first axis is this 49, and the other axis is at least this 20 millimeters, 2.0 centimeters. So I'm going to describe the large mass on the right nasal cavity. I'm going also to tell that it has signs of aggressive behavior because it is eroding, it is destroying bone. This single description is what we need to really summarize the major concern of this case. So now I'm going just to add on the other signs of sinusitis and secondary disease, and we should be done for today. The bone septum is also eroded. There is a slight shift, deviation of the bone septum to the left, but it's quite in the middle, so I'm not going to say it's deviated. It's shift to one side or the other. Also, Kuros classification is 2. Stage 2, type 2 Kuros. Nasal turbines are partially eroded by the lesion as well, and it also reaches the back of the nose, probably infiltrating the tonsil, the pharyngeal tonsil. It could even be originated from the tonsil, but I doubt it because usually tonsillar tumors spread out around the tonsil and not towards the nasal cavities, the nasal fossa. So this is just probably secondary infiltration of the tonsil by the tumor. On the sagittal view, even without contrast enhancement, you guys can actually see how big and aggressive this tumor actually is. This is definitely a enlarged and growing neoplasm on inside the nasal cavity, taking over everything, just destroying everything. You see, this is the middle right turbinate, and you get here, you just can tell where the middle right turbinate is, because the tumor has destroyed its bone structure. So this is a extremely severe disease. This is a most probably spinal cell carcinoma of the nose, a epithelial tumor, very aggressive epithelial tumor arising from the mucosa of the nose and the nasal sinuses. So this is it. Let's see, did I miss anything? No, I didn't. So let's just summarize to make it easier to read, and we should be done for the day. And this is it. We have finished. Let's see if we can report another one. Oh, this is just to make it a easy, smooth end for this video. Let's just report a lumbar spine of a 41-year-old female patient. This should be easy, so you guys can settle down and go watch other videos just after this one. This says there is pain with no trauma, and it doesn't go to the inferior limbs. So this is a lumbar spine pain of a young patient. Just hit download. Did I? Oh, I had already downloaded it. So let's go for a sagittal multiplanar reconstruction. So this is a sagittal view of the spine. There is a tiny calcification on the posterior margin of the L5-S1 disc. The disc spaces, heights are preserved. Bone structures seem fine. No osteophytes. Maybe tiny osteophytes right here. Nothing major, we could just skip that. Facet joints seem preserved. Spinal processes are normal. Let's see if we can find any signs of neural foramina stenosis. No. Nerves are fine. There is some stenosis right here. This is left. This is right. Right side. L4, L5. Let's see the left side. left side. I can also say that the yellow ligament and the bone margin are in contact with the nerve root, which can justify pain. So there is mild stenosis of this neural foramina. Let's just look on the axial view to see if there is some kind of extrusion here that we can tell on the sagittal view. No, the disc is fine, but the ligaments are thickened. So this is a thickened yellow ligament. It shouldn't reach 5 millimeters. It does, and we can eyeball it and compare it to the other. So this is a normal yellow ligament, and this is a thickened yellow ligament. So this could justify the foraminal stenosis because the facet joints are normal and the disc is also normal. No signs of protrusion of bulging discs. So let's report that. Also, you can see there is mild hypertrophy of perivertebral muscles, which can be related to chronic denervation or just be constitutional of this single patient. But we are going to report it because it could be related to chronic pain. There is really no sign of significant arthrosis, nor fractures, nor bulging discs on this case. Maybe a very tiny, very mild bulging disc. You can't really tell. I could just tell this is tiny and has some expensive effect, some compression, anterior compression on the spine, which would help us justify the thickening and the reduced size of the neural foramina. So let's go with that. So let's say the discs are preserved in height, and on L4, L5 segment there is a tiny protrusion. Just a tiny one. Yellow ligament thickening on L4, L5. And facet joints are fine. Mild stenosis of L4, L5 neural foramina or intervertebral foramina, which can be the reason for the chronic lumbar pain of the patient. This is the most important part of this report. I'm going to be sure to summarize that on the end of the report to make it easier for the referring physician to get what he wanted when he ordered this exam. Hypertrophy of the perivertebral muscles. And just summarize it. Just copy and paste a stenosis to the summary, because it's quicker like that. Now this summarizes and ends this case, and we are done. So if you like this video, I'm pretty sure you're gonna like this one right here. Just click here and watch the next one. Thank you so much. Don't forget to hit like, consider subscribing to the channel and sharing this content with people you know enjoys diagnostic radiology. And until next time, I'll see you around.